Hey everyone, welcome back to the channel. If you're new here, hit that subscribe button because today's story is one that every medical professional will relate to, and it's absolutely satisfying. Have you ever had a coworker publicly mock you in front of everyone, only to be proven spectacularly wrong? Well, that's exactly what happened to me during morning rounds at a hospital. And let me tell you, the look on his face when the lab results came back was absolutely priceless. This story involves medical egos, a misdiagnosis that could have been fatal, and the sweet taste of being right when everyone doubted you. It's also a reminder of why we should never let arrogance get in the way of good patient care. Before we jump in, if you enjoy stories about people getting their comeuppance in the most poetic way possible, smash that like button, and let me know in the comments if you've ever been in a similar situation. All right, let's get into it. So this happened about 6 months ago. I'm a resident physician at a large teaching hospital. I'm in my third year of internal medicine residency. For those who don't know, residency is basically where you learn to be a real doctor after medical school. It's exhausting, demanding, and sometimes absolutely brutal. Our days typically start at 5:30 a.m. with pre-rounds, where we check on our patients before the attending physician arrives. Then at 7 a.m., we do official rounds with the whole team, the attending, other residents, medical students, nurses, and anyone else involved in patient care. Morning rounds are where we present our patients, discuss their conditions, and make treatment decisions. It's also where you can either look like a competent physician or get absolutely destroyed in front of everyone if you're wrong about something. Now, I need to tell you about Dr. Marcus Webb. Marcus is a fourth-year resident, 1 year ahead of me, and he thinks he's God's gift to medicine. Ivy League medical school, perfect board scores, comes from a family of doctors. He's technically brilliant, but he has the personality of a cactus and the ego of a neurosurgeon. Marcus loves to show off during rounds. He'll interrupt other residents' presentations to correct them. He'll quote obscure medical journal articles from memory. And he makes sure everyone knows he's the smartest person in the room. The problem? He's so focused on being right that he sometimes misses what's actually in front of him. He treats patients like interesting puzzles instead of, actual human beings. Our story begins with Mrs. Elena Rodriguez, a 68-year-old woman who came to the emergency room 3 days earlier. She'd been feeling weak, tired, and had some abdominal pain. Nothing too dramatic, but enough that her daughter insisted she come in. The ER docs ran some basic tests, saw that her blood counts were a bit low, admitted her for observation, and assigned her to our team. Marcus did her initial evaluation and decided she had a straightforward case of anemia, low red blood cells, probably from some chronic blood loss, maybe from her stomach. His plan was simple. Transfuse some blood, do an endoscopy to check her stomach and intestines for bleeding, start her on iron supplements, and send her home. Textbook case, he said. Nothing complicated. But here's the thing. I was assigned to check on Mrs. Rodriguez the morning of day 3, and something about her just didn't sit right with me. When I walked into her room at 5:45 a.m., she was awake, looking uncomfortable. I asked her how she was feeling. Honestly, doctor, worse. My stomach hurts more today, and I feel like I can't catch my breath. I did a physical exam. Her heart rate was faster than it should be. Her abdomen was tender, especially in the upper right area. And when I pressed on her belly and then suddenly released the pressure, she winced in pain. That's called rebound tenderness, and it's not a good sign. It suggests inflammation in the abdominal cavity. I looked at her chart again. Her white blood cell count, the cells that fight infection, had been slowly climbing over the past 3 days. Not dramatically, but steadily. Her liver enzymes were also elevated. And then I noticed something Marcus had documented but apparently dismissed. Mrs. Rodriguez had mentioned having right shoulder pain. Weird, right? Stomach problems causing shoulder pain? Unless it wasn't weird at all. I sat down with Mrs. Rodriguez and her daughter and asked more detailed questions. Had she had any fevers? Any chills? Had the pain gotten worse after eating? Yes, and yes. My mind was racing. All the pieces were clicking together. The right upper abdominal pain, the shoulder pain, the fever, the elevated white blood cells, the rising liver enzymes. This wasn't simple anemia from chronic bleeding. This was acute cholecystitis, an inflamed, infected gallbladder, and if it had been going on for 3 days without proper treatment, it could be getting worse. The gallbladder could even be perforating, which could lead to sepsis, which could kill her. Mrs. Rodriguez needed a surgical consult. Stat. She probably needed her gallbladder removed, and soon. I ordered some additional tests, an ultrasound of her abdomen, updated blood work, including inflammatory markers, and a surgical consult. Then I documented everything carefully in her chart. I knew what was coming. Marcus was going to be furious that I'd changed his patient's management plan without consulting him first. But patient safety comes first, always. I'd rather deal with an angry colleague than a dead patient. At 6:15 a.m., my phone rang. It was Marcus. What the hell are you doing ordering all these tests on MY patient? His voice was sharp, aggressive. Marcus, I think Mrs. Rodriguez has cholecystitis. She has all the classic signs. She has anemia. I already worked her up. This is a waste of hospital resources. Her presentation has changed. Her pain is worse. She has rebound tenderness. Her inflammatory markers are climbing. You're a 3rd year, I'm a 4th year. I've seen 10 times more cases than you. Trust me, she just needs endoscopy and she'll be fine. Cancel those tests. I can't do that. Patient safety. Cancel the tests, or I'm bringing this to the chief resident. I took a deep breath. Then bring it to the chief resident. I'm not canceling them. He hung up on me. At 7 a.m. sharp, round began. Our attending, Dr. Sarah Mitchell, is a brilliant physician and an excellent teacher, but she doesn't tolerate drama or ego. She cares about one thing, good patient care. We started with the other patients on our service. Everything was going smoothly. Then we got to Mrs. Rodriguez's room. Dr. Mitchell looked at the overnight notes. I see there were some additional tests ordered this morning. Marcus, can you present the patient? Marcus shot me a death glare before launching into his presentation. He described Mrs. Rodriguez's admission, his initial diagnosis of anemia, and his plan for endoscopy. Then he said with unmistakable sarcasm, however, Dr. Anderson here decided to order a bunch of unnecessary tests because he apparently thinks he knows better than the resident who actually evaluated this patient. The whole team went silent. The medical students looked uncomfortable. The nurses exchanged glances. This was inappropriate, and everyone knew it. Dr. Mitchell's expression didn't change. Dr. Anderson, what was your reasoning for the additional workup? I presented my findings. The worsening abdominal pain, the rebound tenderness, the rising white blood cell count, the elevated liver enzymes, the right shoulder pain that suggested diaphragmatic irritation. Based on the clinical picture, I'm concerned this is acute cholecystitis, possibly complicated. I ordered an abdominal ultrasound and inflammatory markers, and I called surgery for consult. Marcus actually laughed, out loud, in front of everyone. Are you serious right now? You're diagnosing cholecystitis based on some vague abdominal pain? This patient has anemia. That's it. The shoulder pain is probably just from sleeping in a hospital bed. The elevated white count is a normal response to anemia. This is first-year medical student thinking. He turned to Dr. Mitchell. With all due respect, this is exactly why 3rd years need better supervision. They see one symptom and jump to the most dramatic conclusion. Meanwhile, we're wasting hospital resources on unnecessary tests. A couple of the medical students actually nodded. Marcus was senior. He was confident, and he sounded authoritative. I felt my face burning. Dr. Mitchell looked at me. Dr. Anderson, are you confident in your clinical assessment? Every eye in the room was on me. This was a moment that could define my reputation as a resident. Yes, Dr. Mitchell, I am. Mrs. Rodriguez's presentation is consistent with acute cholecystitis, and given that she's been here for 3 days with worsening symptoms, I'm concerned about potential complications. Dr. Mitchell nodded slowly. All right, let's examine the patient together. We all filed into Mrs. Rodriguez's room. She looked more uncomfortable than she had an hour earlier. Her daughter stood by her bedside, holding her hand. Dr. Mitchell introduced herself and performed her own physical exam. She was thorough, methodical. When she pressed on Mrs. Rodriguez's right upper abdomen, the patient gasped in pain. Mrs. Rodriguez, can you point to where it hurts the most? She pointed to the right upper quadrant of her abdomen. And this shoulder pain, when did it start? About 2 days ago. I thought I'd slept wrong, but it hasn't gotten better. Dr. Mitchell checked the chart on computer, reviewing all the lab trends. Her expression was neutral, but I could see the wheels turning. All right, thank you, Mrs. Rodriguez. We're going to get some more information, and then we'll be back to talk with you. We stepped out into the hallway. Marcus looked smug. The medical students looked confused. The nurses who actually took care of Mrs. Rodriguez looked concerned. The ultrasound should be done within the hour, Dr. Mitchell said. Marcus, what's your differential diagnosis here? Marcus launched into a confident explanation about anemia, possible GI bleeding, and how all of Mrs. Rodriguez's symptoms could be explained by low blood counts. And you don't think cholecystitis is a possibility? Dr. Mitchell asked, I think it's extremely unlikely. The presentation doesn't fit. Dr. Anderson is overreacting. Dr. Mitchell turned to me. Dr. Anderson, if the ultrasound shows cholecystitis, what would you recommend? Immediate surgical consult if we haven't heard back already. Possible emergency cholecystectomy depending on severity for antibiotics, keeping her NPO, nothing by mouth, and close monitoring for signs of sepsis. And if you're wrong, I swallowed hard. Then I apologized for the unnecessary workup, and we proceed with Marcus's plan for endoscopy and iron supplementation. The next hour was torture. We continued rounds with the other patients, but the tension was palpable. Marcus kept making little comments under his breath about cowboy medicine and residents who think they're smarter than everyone else. I tried to focus on my other patients, but my mind kept going back to Mrs. Rodriguez. What if I was wrong? What if Marcus was right, and I just made myself look like an idiot in front of the entire team? But then I thought about Mrs. Rodriguez's face when I examined her. The pain was real. The symptoms were there. Everything pointed to cholecystitis. At 8:17 a.m., my phone buzzed. It was the radiology department. The ultrasound was complete, and the radiologist wanted to talk to the attending immediately. That's never a good sign. Radiologists don't usually call for routine findings. Dr. Mitchell stepped away to take the call. Marcus smirked at me. Get ready to apologize. The medical students were quiet. Everyone was waiting. Dr. Mitchell came back 3 minutes later. Her face was serious. Team meeting in the conference room. Now. We all crowded into the small conference room. Dr. Mitchell pulled up the ultrasound images on the computer screen. The ultrasound shows acute cholecystitis with significantly thickened gallbladder wall, pericholecystic fluid, and a positive sonographic Murphy sign. She clicked to another image. There's also evidence of a possible perforation with fluid collection in the right upper quadrant. The room went completely silent. Mrs. Rodriguez has a surgical emergency. She needs an emergency cholecystectomy, likely open rather than laparoscopic, given suspected perforation. She's also showing early signs of sepsis. If this had gone untreated for another 24 hours, she could have died. Marcus's face had gone white. All the smugness evaporated instantly. Dr. Mitchell continued, her voice calm but firm. Dr. Anderson's clinical assessment was correct. His physical exam findings were accurate, and his diagnostic reasoning was sound. He potentially saved his patient's life by recognizing a condition that was being missed. She turned to Marcus. Marcus, you're an excellent resident in many ways. You're knowledgeable, you're technically skilled, and you work hard. But this case demonstrates a critical weakness. You became anchored on your initial diagnosis and dismissed new information that didn't fit your preconceived notion. That's dangerous. Marcus looked like he wanted to disappear into the floor. Furthermore, Dr. Mitchell continued, your behavior during rounds this morning was completely unacceptable. You publicly mocked a colleague who was advocating for patient safety. You let your ego interfere with good patient care. That ends now. She looked at me. Dr. Anderson, excellent work. You trusted your clinical judgment even when challenged, and you put patient safety first. That's exactly what we want to see in our residents. The medical students were staring at Marcus with a mixture of shock and secondhand embarrassment. The nurses looked vindicated. They'd been worried about Mrs. Rodriguez, too. Dr. Mitchell pulled up Mrs. Rodriguez's labs. Her inflammatory markers are significantly elevated. Her white count is now 18,000. She's becoming septic from a perforated gallbladder that's been leaking infected bile into her abdomen for at least 24 hours. She let that sink in. Surgery is already on their way. We need to start broad-spectrum antibiotics immediately, get her typed and crossed for possible transfusion, and prepare for emergency surgery within the next 2 hours. The next few hours were a blur. Mrs. Rodriguez was taken to the OR for an emergency open cholecystectomy. Her gallbladder was gangrenous and had perforated, exactly as suspected. The surgeons had to wash out her abdominal cavity and place drains. She was in surgery for 3 hours, but she survived, and she recovered well. A week later, when she was getting ready to be discharged, her daughter pulled me aside in the hallway. "Doctor, the surgeons told us that if you hadn't caught this when you did, my mom might have died. They said another day or two, and she would have been in septic shock." Tears were streaming down her face. Thank you. Thank you for listening to her. Thank you for trusting your instincts. You saved my mom's life. I'm not going to lie. I got choked up. This is why we do what we do. This is why we endure the exhaustion, the long hours, the stress. For moments like this, when you actually make a difference. As for Marcus, he was required to meet with the residency program director. He had to write a formal apology to me, to Mrs. Rodriguez, and to the team. He was also placed on a professionalism remediation plan. But more importantly, something changed in him. A few days after the incident, he pulled me aside. "Anderson, I owe you an apology. A real one, not just the one I was required to write." He looked genuinely humbled. I was so convinced I was right that I stopped listening. I stopped looking at the patient. And I was a complete jerk to you in front of everyone. I appreciated his honesty. We all make mistakes, Marcus. The important thing is learning from them. I could have killed that woman because I was too arrogant to consider that I might be wrong. He shook his head. "That's going to haunt me." "Let it make you a better doctor instead," I said. "That's how we honor our mistakes, by learning from them and never repeating them." This experience taught me several important lessons that I think about every single day. First, trust your clinical judgment. If something doesn't feel right, investigate. Don't let someone else's confidence override your own assessment, especially when a patient's life is at stake. Second, ego has no place in medicine. The moment you think you're too smart to be wrong is the moment you become dangerous. Every patient deserves a doctor who will question their own assumptions and remain open to being wrong. Third, anchor bias is real and it's deadly. Marcus got anchored on anemia and couldn't see past it, even when evidence was right in front of him. We have to actively fight against our cognitive biases every single day. Fourth, always advocate for your patients, even if it makes you unpopular, even if it means going against a senior colleague. Patient safety trumps everything else. Fifth, humility saves lives. The best doctors I know are the ones who say, "I don't know," when they don't know, who ask for help when they need it, and who treat every patient and every colleague with respect. Dr. Mitchell told me later that she knew I was probably right the moment I presented my findings, but she wanted to see if I'd stick to my guns when challenged. She said it was a test of character as much as clinical knowledge. The best doctors, she told me, aren't necessarily the ones who know the most facts. They're the ones who combine knowledge with clinical judgment, who listen to patients, who remain humble, and who have the courage to stand up for what's right even when it's uncomfortable. Looking back on that morning 6 months ago, I remember how scared I was. Not scared of being wrong. I was pretty confident in my diagnosis, but scared of the professional consequences. Scared of being publicly humiliated. Scared of damaging my reputation. But you know what would have been worse? If I'd stayed silent and Mrs. Rodriguez had died. I think about her sometimes when I'm doing morning rounds and evaluating patients. I think about how close she came to a terrible outcome simply because one doctor was too arrogant to reconsider his diagnosis. And I think about Marcus, too. He's actually become a better doctor since that incident. He's more careful, more thoughtful, more willing to listen. We become friends, in a way. He still quotes journal articles and shows off his knowledge, but now he does it to teach rather than to prove he's the smartest person in the room. Last month, he actually asked my opinion on a complex case. Anderson, come look at this with me. Something feels off and I can't figure out what. The fact that he could admit uncertainty and ask for help, that showed real growth. Medicine is humbling. It will knock you down, expose your weaknesses, and remind you of your limitations. But it will also show you what you're capable of when you trust yourself and put patients first. So there you have it. My colleague laughed at my diagnosis during rounds, and the lab results proved who was really unprepared. But more than that, it proved that clinical medicine isn't just about memorizing facts. It's about observation, critical thinking, humility, and courage. Mrs. Rodriguez made a full recovery. By the way, I saw her in clinic last month for a follow-up. She brought me homemade cookies and a card that said, "To the doctor who listened." I keep that card in my locker at the hospital. On the tough days, when I'm exhausted and questioning whether I'm cut out for this, I look at it and remember why I'm here. If you enjoyed this story, please hit that like button and subscribe for more medical stories and life lessons. Drop a comment below if you've ever had to stand up for what you believed was right, even when everyone doubted you. I'd love to hear your stories. And remember, trust your judgment, stay humble, and always put your patients first. Everything else will follow. Thanks for watching, and I'll see you in the next video.